Good evening. I'm joined in the studio tonight by a panel of experts who are here to answer your questions about planned changes to our health and care system. We also have a live audience here who'll be asking their own questions. Welcome. Healthcare experts have developed the Jersey care model to improve services so that islanders receive the care they need, when they need it, and in the most appropriate place for that care. But this shake-up of services has prompted many questions. Are islanders going to have to foot the bill for these changes? How do charities fit in? And where will we get the staff to implement the plans? With us tonight to answer these questions, we have Medical Director Patrick Armstrong, Chief Nurse Rose Naylor, James Lefevre, who chairs the Health and Care Partnership Group, and the Director of Improvement for Health and Community Services, Dr. Anushka Muller. We already have some questions from our studio audience ready, but if you'd like to ask a question, all you have to do is go to Slido online, type in Jersey Care Model, and then type in your question. If you can see that someone else has already asked your question, if you give it a like, it'll make its way up to the top of the priority list. So that's the best way to do it if there is already a question that is pretty similar to yours. And please remember that this panel tonight is made up of experts, not ministers, so they won't be able to answer any really political questions about health or the care model. But before we go to our first question, I'd like to just ask the panel. Well, my question for Dr. Muller, or for Anushka Muller, has been asked actually by somebody on Slido, Catherine Curtis. Can you sum up in one sentence what the Jersey care model is? Well, I think we'll give you a little bit more than one sentence because it's quite big, isn't it?
Thank you, Kathy. Yeah, so I will try to make it as short and easy to understand as possible. The Jersey care model is a bespoke model that has been developed for Jersey and for islanders, and it's particularly developed to meet the changing health and care needs of islanders in the future. It's based on best practice, and it's focusing with the aims on preventative care, working together across the health and care system, and on person-centered care. In essence, it's a model, as the word says, but there's also a 5-year program of work to change the way we are working and to develop new services and laying some of the foundations to achieve this model. This 5-year program has started last year and lasts over 5 years. It has been agreed by the States Assembly and is funded by the government.
So what I notice that's different in a few years' time then, if I get sick? What do I do?
The key aim, so what we see at the moment is that we see our islanders being admitted to hospital or having to attend the emergency department if that's not really necessary. The reason for that is that at the moment, or in the past, we didn't really have the community services in place. So for example, if somebody, an islander has an issue overnight, which could be solved by a specialist nurse who could come out to their home, in the past that wasn't possible. So they would have had to go to the emergency department, which means probably waiting a few hours in the hospital, maybe even being admitted to hospital, which is just not desirable. Whereas now we have services in place, and we'll develop these further, that people are seeing at home in their usual place of living, and they can be seen there and then, and after maybe 20 minutes everything is solved, and during the night they can just go back to bed, for example.
Okay, Rose Naylor, you're in charge of all the nurses. How is this going to affect nurses? What do they think of it all?
So I think when we started to develop the care model and nurses were involved in that development, what a lot of nurses said is that they talked about their frustrations for their patients who quite often they saw and cared for in hospital beds where they felt there was a much better place of care for those people. So that was something that we heard very early on from nursing staff. I think in terms of how it's going to affect nursing in future, I think it gives nurses lots of opportunity to work differently, to care for their patients in the right place, at the right time, with the right skills. And I think, if I use one example of some recent changes that some of our nursing staff have made in respiratory care, we've had a group of nurses who have predominantly previously cared for patients within intensive care. They thought, how can we care for these patients differently and stop them having to repeatedly be admitted to hospital? So that team of nurses is now very much community-based. They support patients with chronic conditions out in the community to support their health needs and prevent unnecessary hospital admissions and fast deterioration. So I think a lot of nursing staff are very excited about the opportunity that this offers, and some nurses see it as a way in which they can advance their careers in a way that perhaps they couldn't do previously by taking on new roles in different parts of the services.
You talk about going into hospital as a really bad thing, but some people might feel more comfortable and kind of secure if they're in hospital.
Yeah.
How do you get over that?
Yeah, absolutely. And we recognise, you know, the General Hospital has been at the heart of our healthcare system for a very long time in Jersey, and that this is a really big change for people. But again, as we talked about on our roadshows 2 years ago, being in hospital isn't always necessarily the best thing for you. There is something called deconditioning that happens when you're in hospital, and the older that you become, the quicker that deconditioning happens to your muscle tone and your mobility and lots of other things. And also you can pick up infections when you're in hospital. So really the hospital should be a place where we have people come in who need acute care delivered in a building that maximises the skills of those doctors, nurses, therapists and everybody else in that building, but then are supported better in an environment they're much more familiar with at home.
Okay, now if we go to Patrick Armstrong, we've heard like what nurses are thinking. What about senior medics? What do they think of all this?
Well, I think I'll just build on what Rose has said about right person, right place, right time. I and many of my colleagues see people with health issues that could quite easily be managed by other healthcare professionals in a different environment. And what that does is gives us more time to concentrate on people who perhaps have the more complex problems. And also, if we're not having to see so many people in the hospital, it means those people with those really complex needs will be seen in a more timely fashion. But I think what the Jersey Care Model also has, the way it's been set up, will provide us with is a framework so that when we're looking at new pathways, when we're looking at delivering care in a different way, we have a structure about how we implement that change across the whole system. The medical knowledge base doubles every 73 days at the moment, and it'll get quicker. So healthcare will change.
What do you mean by that, medical
so the knowledge that we have around conditions, how they're treated, when you look at the literature, the information out there that we have that is discovering new treatments, etc., that doubles every 73 days at the moment. So what is inevitable is that healthcare will change, and this also provides us a way of making that change so we keep up to date. And also the other thing the Jersey Care Model will do is hopefully leave us with that legacy of how we bring about change across a whole system, because that's probably something that we haven't been able to do as effectively as we would have liked so far in Jersey.
Okay, now just come to my last panel member. James, how is the charity sector going to cope with all this? Are you going to be inundated with work?
Well, there's a very vibrant charity sector in Jersey. We're very lucky. There is still a sense of community, and there are a huge range of charities, many involved in health and social care. And they are really up for doing as much as they can, particularly around some of the early work with people, so the lower level interventions, supporting people before they become really unwell, but also signposting people to other services as well. And we think that signposting is one of the most important things. So one of my tasks is to build the network that was already there, but get the charities together to work with government, but to work with each other as well around some of the new things that they can develop. Because I think we have to concede that charities can be more nimble and they can initiate things more readily. And if they prove to be successful, then they can bring them back through the partnership to government as ideas that really should be supported going forward. So it's a very interesting area, I think. I think COVID did teach us, one of the better things we learned from COVID was there is this strong sense of wanting to be involved and wanting to support and help people. And I think we really need to capitalise on that, because I think it's really important to understand and accept that the government can't provide every service. There is room for others to be involved in some of the key areas, in mental health, where I worked previously, in supporting people with diabetes, in many of the other areas, working with the big ones like family nursing and with Jersey Hospice, who provide excellent services, to make sure that they're tailored to fit in with the model. And genuinely, the charities have the ability to inform government, of health in particular, of priorities that they think are out there, and gender support to develop and deliver those services as well.
So you're going to be in charge of coordinating all the kind of the charities together to do all this kind of liaising and working and...
So we've established a forum. Now we meet quarterly, which is quite formal, but was really gratified. We've got over 40 charities who have committed to be part of the process across the range, from some of the physical conditions through mental health, as I've said before. And the quarterly meetings are where we can discuss some of the broader themes, some of the things that are coming online. But between meetings, there's lots of discussions that go on involving people from the sporting community, involving people around any number of different new ideas that are out there. Test them, see who's up for doing it, and bring them back to the government that these are ideas, that there is a strength of feeling behind doing some of these things. How about it? And my task is to try and make sure that that relationship is strong, that the communication is good, and that the charities themselves absolutely feel that they are part and parcel of building the new model.
Okay, thanks. Well, we've introduced all our panel. It's time now to go to the audience for their first question. So firstly, we'd like to hear from Lady Broomfield. What question do you have today?
Yes, well, James, I was just listening, and that was really interesting, and I attended the St Martin's meeting last week, and I spoke to a lot of the charities afterwards, and the impression I got was the money. There were people waiting to come to your charities and to help you. So my question was really about the finance. And it was with this plan for care in the community, and as the charities will have to employ many extra staff to support patients in their own homes, how much extra money are the states planning to give to the charities to enable them to fulfill this commitment?
I think,
So maybe
Anushka will be
Anushka
answering
might.
this to begin with.
No,
That's all right.
I will add to it.
I think James would probably like to say how much money he'd like, but Anushka will explain how much there might be.
It's a question of finance.
Yes,
And
okay.
I do hope you have some backing.
Yes, and I know this has been raised several times. It's a concern. It's probably not a straightforward answer. It links back into definitely. So one thing is to clarify, it's not about moving work into charities and expecting them to deliver work that is currently being done by the government, for example, or to expect more work being done by the charities and not funding it. As Patrick already explained a little bit more around developing pathways. So where we are going to is we want to create a system where we know charities provide fantastic services, but not all of them are coordinated between each other and between the government. So how can we develop something which fits smooth to the islander? Based on this development and this agreement, saying this is what we actually want to provide as a service and who can provide that. There might be something from a government perspective that needs to be provided. Then there's something from one organisation, from one charitable organisation and the other. It's coming together, working it out and saying this is what we want to provide and what resources do we need. What will it cost in the end? And putting this together and say, right, this is what it costs. Do we have the resources at the moment? If not, then we need to say to government, this is an additional cost, so this needs to be funded. If from a political perspective this is wanted, this needs to be funded. However, at the moment we have a huge range of resources across the system available. So at the moment it's about what do we want to deliver together? How can we use resources in the most effective way? So there's a little around. Definitely, if there are more resources required, we need to define what they are before we actually say this is what it costs and how we fund it.
Okay, James, do you want to have your go?
I mean, the charities do excellent work. They have a core of employed people who are salaried, but many of them also have a huge cohort of volunteers who give of their own time, and that is absolutely invaluable. And they can do some really important early work with individuals. People perhaps who've had lived experience of a particular condition can then share their experiences with other people, and they don't necessarily require payment for doing that. Peer support is a term that's used for that, and some of the charities do that already, where if you're newly diagnosed, you can meet with someone who's able to talk to you about their own experience and the sort of advice that they gained and the sort of experiences they had, and that can help people avoid escalating their condition, or it can certainly help mitigate the development or the extension of the condition. And the people who do those things, the peer volunteers and the volunteers generally, very often get an enormous sense of self-esteem that they've done something valuable, they've made a contribution, they've given something back. And I think that's something we've really got to work hard on We have an ageing population, but many people are going to age, we hope, with very good health and want to do things beyond their period of paid employment. And our task is to make sure that we reach them, we capture them, and we get them involved with the charities doing any number of different low-level interventions. And that's not to be dismissive of what they do, but it's about friendship, it's about supporting people, it's about being there, that there's someone that others can talk to. And I think we haven't acknowledged that enough effectively about some of the ground force work that we can really do in things like diabetes, in terms of mental health, in terms of many of the other areas. If you talk about hospice, they definitely have employed staff, but they have many, many volunteers who help them as well. And I think that's the richness that the charities have, because they are based on the ground and they understand what the conditions are like to live with very often. And they are very, very powerful advocates as well. And when health is seeking advice and input into developing new services, the pathways, there's nowhere better to go than to the charities who will already be working with people who are living with these conditions, or perhaps are carers for someone who's living with a condition. And I would say that's another area where I think the charities can be really, really helpful, is in supporting the carers and the loved ones, because I would suggest that that's an area where there has been not enough attention and acknowledgement. They're doing some fantastic things.
I don't realise about volunteers. I mean, they're amazing and wonderful, but you know, they do say, I'm so sorry, I've got to go off and do something, so they're not consistent. It's the paid person that is really going to be consistent. I mean, I love the volunteers and we all do something, but it's not going to be that every day you're going to have somebody coming unless they know they're on a salary. So this is the extra staff that I'm talking about, who are going to back up your new extended care in the community.
It's a bit of both. I think there's opportunities, and people who volunteer very often can then find gainful employment with the charity, and that's been a very good way into getting involved, is by volunteering to do things, and then the vacancy will come up, or an opportunity arises, or there's a development of a service that's been supported by the health department, and that's where I've known of individuals who've made that progression, and that's been a win-win in every sense.
Can we ask a part of the question? I'd be interested in knowing, maybe it's Manushka, whether in developing the Jersey care model, you have a figure in mind of what the financial contribution currently is from the charities, and what you think it might be going forward over this 5-year plan, because that cost has to come from somewhere, and principally is coming from the islanders who are fundraising and doing things. I mean, crazily, I signed up to do the London Marathon for Headway a couple of days ago. You know, I'm going out to raise money for Headway for its services. So maybe it's a question for Nushka. How much is the charity sector currently providing, and how much do you think it's going to provide going over this 5-year plan?
It's a good question. I don't have a figure for what the current provision is in financial figures. However, we do appreciate and we do know it's they recruit large resources, and they do have a lot of charitable funds coming from islanders. So that's very much valued. We do have already contracts in place with a number of charities to support them. We do have worked with a number of them together to develop services, and we're moving into a different direction where we're saying, let's take a wider commissioning approach, commissioning from not a procurement, but actually analysing the needs of what needs to be developed, what needs are there for islanders, what do we have available, how can we best meet these needs, and what are the resources we need for that. And so there is working with both systems, what is available in terms of public finances and public resources from a clinical and professional perspective in the government, but also what is available from a charitable sector. And we've heard a lot where charities say, we want to continue as a charity, being independent, using our charitable funds, and we don't want to, completely be funded by government, but there might be areas where it's really useful and helpful to support the charities, and every charity is different in that respect. So it's important going forward to very much take an individual approach, with each organisation to work out how we can best work together and use the existing resources.
I mean, do you think, as you don't have the number, you might be able to commit to finding out that number over a, you know, I don't know how many weeks, months it would take you to do that? Because it seems to me that unless you know these numbers, you're not actually going to be able to move it forward, because you're building upon something you don't know. You don't know what it's going to cost, because you don't know what it costs today. And I think in order for you to be successful,
With many charities, the government has service level agreements with various charities, and the government pays those charities to do work. But then some of the smaller ones might have a contribution to what they're doing.
I think if you're talking about the overall, basically, financial resources charities have, that's their commercial personal information for each organisation. So I can't commit to, bringing information together which we basically don't own or don't have access to. I think more important is that we're looking at a long-term funding model. So there's not just around the charities, but it's how the health and care system is actually funded in the future. And that is a political decision for the long term. However, what we're doing on is at the moment, as committed by the current government, is to find options for sustainable health funding in the future, and what are the costs of those. So that projection of costs, which you may have referred to for the island, what does that look like? So that is a project and currently undertaken, and that will feed into the new government, and it's for the new government to make that decision and to take this forward.
And if you do want to know how much the government spends on grants and service level agreements with charities, that's all in the state's accounts every year. So that is on gov.je website. So we're going to move to a few Slido questions now, and then we'll come back to the audience shortly. If the Jersey care model is successful, what does success look like in, say, 5 years? Who would like to go with that one?
Shall I start from a more technical perspective, and then I think there's something from a more clinical and experience level. So from a program perspective, we have a range of indicators, as you would expect, performance measures in terms of activity. As I mentioned at the beginning, the aim is very much to support in the community, so we would measure that, and to avoid unnecessarily hospital admissions, so that will be captured as well. If you're interested from a kind of public perspective, this is online, this is available, a huge range of metrics. However, I think apart from that, that's what the program will measure, whether we see a shift of activity which is currently in the hospital and shouldn't be in the hospital, and are actually further supported in the community. But there's the other side from a more personal perspective. What does it feel like for the islander? What will be different? And what we aim for is that it feels it's more connected, it's a smooth journey. If I feel ill, I know where to go to. I feel better connected between charitable organisations, the government. I know where to go to, and I feel more being part of a journey guided through rather than having to go to different silos. So that is definitely a personal aspect, and I'm able to be cared for and supported at home more, and don't have to come to hospital if it's not necessary.
Okay, Patrick, how will this affect GPs? Because at the moment, if I'm ill, the first place I would probably go is, well, maybe the chemist first to try and save some money, but then a GP. Will that change?
No. I mean, our GPs are clearly vital within our healthcare system. They are the gatekeepers of our health and our healthcare needs. So that won't change. I think in answer to the question, the sorts of things I would like to have happened is that when we're designing pathways and when we're looking at how we provide care, the first thing we start with is the person, the patient, the person who requires that care. I think up to now, too often, the pathways have been driven by organisations, by professional groups. It's been fragmented, and you really need that pathway right through the whole healthcare system, from primary care into secondary care out. And the other bit we haven't really mentioned tonight is about prevention. So hopefully you won't need to go to see your GP if we get the preventative side and put much more emphasis on staying healthy, both physically and mentally.
Okay, when you say that the pathways at the moment are driven by like organisational needs rather than the person's needs, how does that manifest itself to a patient? What difference will I see when it's no longer the organisational needs that are being prioritised, but the person?
Well, you feel, I think Nuska's alluded to it, as a patient or someone accessing healthcare services, you shouldn't really know which organisation you're in. You should just flow through the system. You shouldn't feel like, well, I'm in primary care. Oh, hang on a minute, I've got to be referred into secondary care. I'm going to have to wait to see a consultant, and I've got to then refer a letter to a physiotherapist, for example. You should just move to the right place within the system as you require it, and that's understanding the skill set of the people that you're in front of, and who can provide that type of care.
So hopefully that's what we will be feeling in 5 years' time, when we feel that we need some.
What we really want to see is that the development, enhancement of skills, all healthcare workers, I would include doctors in that, but particularly the contribution by other professional colleagues, nurses, allied health professionals. There's so many other things. Your pharmacists these days can provide so much advice and so much care that they don't currently do, so that you don't need to go and see your GP necessarily. You don't need to come and see me. You can just go straight and see a physiotherapist.
Rose, what about for nurses?
Well,
What do you hope that you'll see that's different in 5
well, I
years?
think just building what Patrick said, I mean, we've heard from somebody today who he's explained their struggle around navigating around our current system, which is really difficult. There's so many handoffs at the moment. So in 5 years' time, we really want a system, as Patrick says, that people don't feel that they find services by accident rather than by design, and that actually staff support patients wherever they are within that system. It's not defined by I work in the hospital or I work in hospice. And so from my point of view, thinking of it from a professional perspective, I would like to see success in 5 years as us being a destination of choice for healthcare staff. So as well as growing our own and expanding on our talent base locally and maximising the local expertise that we have here, building on that and actually people seeking us out. We've got some really good early examples of that where people want to come to Jersey because they can see what we're doing around the Jersey care model and really think it's an exciting opportunity to really drive and influence care in a way they've not been able to do in another system. So that whole integration of a system of health and care working together very differently will be one evidence of our success in 5 years' time.
So more desire of people to come and work here from elsewhere.
Yes,
Okay. Another question that's been submitted. Who holds accountability when things go wrong? Who can answer that one?
Depends what's gone wrong, I think.
So if it's in you, so it depends which area it's in, does it? Like it does now?
Ultimately, within health and community services, it's the Director General. We have only 3 executive directors from health and community services sitting here, but we each have our own portfolio, and we have delegated authority and accountability that goes with that. So it really does depend on the actual thing that you're talking about.
Other organisations operate within their own sovereignty and their own structures as well. So as partners within the Jersey care model, we are developing that accountability framework in terms of how we work together moving forward in an integrated care system. So how it exists today will not be how it exists in the future. So it is something that will change over the next 5 years as we continue through this journey.
Okay. Another query from Slido. If you've got some questions you want to ask, go to Slido, just Google it, go to Slido, put in Jersey care model when it prompts you to ask and asks you what you want, which Slido event you want to go to, and then put your question in. If you see a question that you'd like to ask, just give it a like and it'll pop up. What is the funding model? How will services be funded? Is there anything more we can say about that? Anushka?
I think we touched upon it. So at the moment, if we look at the funding model, there are almost two funding models. So one is I've talked about this 5-year program of work, which has its own funding model.
Preparing it and making it happen.
Exactly, and also establishing some services to try them out, to evaluate, is this the right thing to do? And to, out of this, coming forward to say, right, this is what we need in the future. In addition to that, there is a long-term funding model, of course, necessary. As we know, the population will grow, health and care needs will grow, so as everywhere, all across the world, health and care costs will go up. So how do we sustainably keep the funding up to meet these demands and to be able to provide health and care services in Jersey? As I mentioned before, it's a political desire at the moment to find that the funding model, and the options for that has been put into the government plan. As I said, there's a project working on at the moment to inform the new government, which will be in place in the summer, to work that through. So it's a political decision where we probably see more details beginning of next year, mid next year.
So the politicians will need to decide on that, maybe ministers, proposition to the States Assembly, all that kind of stuff, before it's really known. Okay, where will you get the staff from to cover all these plans? Yeah, I mean, Rose, you've said that hopefully lots of people want to come here when they see what's happening, but do we need more staff in order to get to that stage?
Well, so people who came to the roadshows will have heard my talk on the workforce piece in terms of what we're already doing. But in terms of some of the other questions before about charities and extra staff and all of those pressures, again, we're looking as a whole system here. So we're looking at what we've got in terms of our health and care staff resource collectively together. And some of it is about moving people from different places in employment now to work in other parts of the system. And that's really the work we're doing at the moment around how we enable that to happen within the mechanisms that we've got, because obviously there are some terms and conditions issues that we need to iron out in relation to be able to do that. But we've already had some success with that, with our nurses that have moved into rapid response services, and with some of the early work that we've done with hospice as examples. So in terms of the whole system, there are a lot of people that work in the system now. We're trying to do more to grow our own. We're trying to offer greater opportunities for people to enter the health and care sector in Jersey. Again, the care sector as a whole is an area that is really challenged. It's challenged at the moment. And again, that's something that we really need to have a focus on. And that really needs to become a much more desirable career for people to go into so that we can continue to sustain that service. So I think in terms of how are we going to staff this, I think the indications that we've got so far in terms of our expansion of our on-island programmes for some of our professional roles are showing really good indication in islanders wanting to come in to work in this industry. And it is about maximising them. We'll never be self-sufficient, and nor should we be. We'll always have to bring in some clinical expertise and experience from elsewhere, but we can supplement that really well. And again, for the benefit of people who weren't at the roadshows, just as a little example number, we've got 54 nurses in training in Jersey. They are training to go into jobs in Jersey. We don't lose nurses. Once they train here, they tend to stay here. We've been running those programmes over a sustained period of time, and there are lots of others, but I won't take up the time.
I think probably what was maybe one of the things that was behind that question is the kind of concern out there, whether it's justified or not, that there's a lot of staff shortages in the hospital. Because that concern pops up in the media a lot, doesn't it?
Yeah, so in terms of our position around vacancies, we've got a really improved position, which is improving month on month. We aren't an outlier in terms of our vacancies. What's really affected all of us that work in healthcare is COVID. You know, we've lost staff on short-term sickness. That's affected the care sector and the care agencies as well. So there's lots of different factors that affect the number of staff you have available to do a shift on a particular day. But our overall vacancy position is in a healthy position overall. We've got some pockets where we've got issues, and we've reported that previously, particularly in theatres. And at the moment, we're doing an international recruitment campaign, and we're interviewing nurses this week to support some specialist posts in theatres.
Is that the same for you, Patrick, in your area?
Well, currently we're actually, certainly within secondary care, I know that there are challenges for our GP colleagues, which they have articulated, but within secondary care we're finding we're recruiting really easily at the moment. We're putting jobs out and getting much greater response to that, to those jobs than we would have. I think it's only one area really where we're struggling, in areas we've traditionally struggled in, getting really good response.
Because COVID is calming down?
Well, I think part of it is that there are people working in the NHS where it is incredibly pressured and very different environment to what we have in Jersey. They want to move, and so to be honest, the UK government's done us a favour by attacking people's pensions as well, which has been helpful. But just getting back to what Rose was talking about in workforce, I think, and the impression that we just have to employ more and more and more people. Part of it, as we've alluded to, is upskilling other professional groups, so things that doctors do today, they won't need to do. So if a nurse can prescribe drugs, for example, there's a lot of efficiencies within that, with people having increased skill set. And that actually then leads to attracting people to come to Jersey, because we can train them, give them those skills, and education and learning and development is a large part of the Jersey care model as well.
Okay, well, just one or two more questions from Slido, then we'll come back to you in the audience. Are you happy with the strength and role of the Health and Care Partnership Group? Would service users sit on it in the future? Now, James, you're chairing it, so I expect you're happy with it, are you? Or...
I am. It's early days. We've had the first big meeting, but we're having meetings in between times. But it is about really having the charities there so that we listen to what they have to say, we hear their voice, and they can help shape what's required. But what they will also do is, as and when we're looking at new services or reviewing services, they will be ideally placed to nominate and to identify people that are, they know of, service users who are in their own orbit and are already involved with them. So if there's something happening around asthma or diabetes, or there's something happening around mental health, we will know where to go in the first instance to really ask for service user input. And that's something that's coming through quite strongly. I think, Rose, you're going to be working on that as well. They're not the sole location of where we're going to find service users, but it is an important starting point, because the charities are closer to the ground than we are, rather than health is, and they will be very well placed with those that are in touch with them.
Okay, there's another one for you now, James, before we move to Martin O'Neill. We'll go to you next, Martin. The ambition to facilitate community partnership through the Health and Care Partnership Forum is welcome, so that's a tick for you.
Good.
Can you share the process for recruiting charities to this forum? How did you do that?
It was simply about seeing who was out there, and I'd worked in the charity sector myself for 10 years, so I knew quite a lot of the individuals, but we spread the invitation very broadly, making sure that we covered both physical conditions, mental health conditions, and we got a mix of some of the smaller charities as well as the bigger ones, but the invitation is there for anyone else who would be interested. And as part of the process, I met with over 80 people and sought their input and their advice, and some were very keen to become involved, some thought they might come back a bit later, but we really were very, very particular in making sure the spread was wide in terms of the diverse range of charities around their size as well, and the areas of activity that they're involved with. So it will change, it will grow, and at the meeting we had the first one of the questions we asked of those that were there, who else should be here? Which other charities should be here?
So it's still open to more charities if they're interested?
Absolutely.
Okay. Now, if we move back to the audience, we have a question from Martin O'Neill.
Yeah, thank you for having me here.
It's all right, you're welcome.
So, our Healthcare Minister's recent report on the 19th of April suggested that out of 100 persons sought to work in the care environment, 33 were hired. So in order for us to implement our care model, we must have these persons within the sector previously. So not relying also on charity handouts, we're implementing a new way of doing health, which is island-wide, and all its complications to come with it have yet to be still ironed out, meaning further costs and further issues. All of this explained by Government of Jersey in a total of 8 public hours. 1 hour is included this evening. My question was less simply, we cannot do more. If we cannot provide the staff to make the care model work, how can we safely implement this model? What happens if it goes wrong? Also, is it not better that we put the brakes on this until there are adequate discussions with the entire island? Because what I get from the public, and there are many who speak to me, they do not know what's happening with this Jersey care model. They haven't got a clue. So that's basically it.
So you want to postpone it until there's more public consultation?
Yes. Because the persons whom I've spoken to are chronically ill patients like myself, whom are not happy with the changes, not because it's changing, but because they feel that to be left to a charity's grace with volunteers, etc., is not good enough. Already, chronically ill patients don't feel... But it's not the intention, but that's how it's portrayed. So obviously, public will need to be clear that the communication has not been done properly if public are thinking that it's charities who are now doing the work, etc. So there needs to be better communication from the hospital, from health, to the public, so as they can understand exactly what it is that you're promoting, because we don't know. I'm telling you as a patient, as a person who spoke to patients, what we are saying. It's all well and good that you say what you want to do. It's what we want as well. It's our service. It's for us. We have to have a say. We have to be listened to, not 8 hours. It's not enough. It's not enough time to debate and such.
So is there any intention to go out and talk to people further about what they might like to see from this new way of working?
So first of all, I would just say it has been widely communicated. There were roadshows in every parish before it went to the States Assembly. So that was prior. And then the Jersey care model as such was debated in the States Assembly and agreed. So what we're doing now is implementing what has been agreed beforehand by the States Assembly. I think there's also a point, I think very good point around communication, and I think you can never communicate enough. It's very important. So thank you for that point. We've started with doing some roadshows. We're having this event today. I absolutely appreciate the more changes coming in, the more, of course, it needs to be communicated. And
I think
it's not enough.
Wasn't
in total, between the roadshows that you've done in this year, it's been 8 hours total, I've calculated.
So presumably the 12 parishes would have been more than 8 hours. That was like in the lead up to what the States Assembly decided.
In the lead up when? A couple of years ago, when people have forgotten what's happened.
And then wasn't there also a leaflet that went to all the households in the island to explain what the intention was for this change? So I know that's not time spent face-to-face, but not everybody wants to have a face-to-face meeting. Some people just want to read about it online. Some people want to read it on a piece of paper. Some people want to come in and speak to people. Some people want to do it online, like the people who are watching tonight. So we have to try and cater for all the different ways that people want to hear things. But I'm sure I have heard that there is going to be more of those kind of roadshows later as developments.
To hold this back instead of spending and wasting everyone's time, because it wastes your time as doctors and nurses, etc. Hold this back. We have enough with a hospital that hasn't even been built yet. We have patients who complain to me because when we complain to government, we are not heard, we are not listened to. We have issues with the health system that we have at the moment that is not being looked at properly, and yet we are being advised that we must implement a new care model that, in my opinion, has massive errors.
Well, unfortunately, the States Assembly have decided it, so they're the ones that get elected.
I understand that.
So if you want to stand for election, maybe you'll have more say.
Possibly, yes. They agreed a model, yes.
There's nothing in black and white to say what that model
Well, I guess the model has to be...
Hang
on, okay. Should we let Patrick have a say what he wants, what he thinks?
Because you're right, I can completely understand we're talking about a model. And if... I can understand why patients would want to go, well, what does that mean to me and my condition? And I think what's happened up to now is that we've put in structures and we've put in groups. And as I said earlier on, what attracts me to the Jersey care model is I now have a framework in which to go, okay, when we look at this particular condition, how are we going to treat it? And that's one of my roles, to chair the Clinical and Professional Advisory Forum. And the purpose of that, which is made up of multiple different professionals, is to start looking at specific pathways. And at that point, and it sits alongside the group that Rose will be chairing, which are people with lived experience and user groups. So as we develop the pathways, it is absolutely vitally important that we come out to people who either care for people, or most importantly, people who have those conditions, to get your input into those pathways. So it's not, diabetes is always the one that we talk about. You know, we don't just look at what we do in the hospital about diabetes, but it's how you're looked after through the whole system. You know, how the burden of having a chronic condition affects your mental health, and mental health and well-being, and how we support people in that better than we do now. So it's a much more joined up service. So I think there's been a lot of structure put in, but I think you're right. People don't understand how it will affect them and their particular condition. And I think that's really the next stage.
For me personally, because I'm mesh afflicted, I was damaged by a failed medical device. It's prominent, it's in the news, but I am still not recognised. I have no condition. There is no report of my condition. There are 14 other people exactly like me, possibly worse. There are more people who are out in the community who probably don't even know that they are damaged by mesh. And yet, I'm hearing about the pathways that are being created, and yet with my prominency, my pathway is still not recognised. No one recognises.
Probably best not to kind of talk about personal health conditions, because it's difficult for people here to kind of answer you on that.
I'm putting down a framework because it's what I've experienced as a patient. My pathway is not a recognised pathway. We're talking about pathways to be created. So this is one that we're saying, well, pathways are we need to create. We want to speak to patients. I'm willing to speak. I've been asking to speak with our health community services and offer this experience of what I've gone through.
Well, I think that's something that I think health professionals do want to hear from people with lived experience, and I think that will be something that will be taken on with this model. But I think we need to move on now, because there are other people who've got questions, if that's all right.
Can I just add
Oh, yeah.
just one point? Just
Okay.
something that you said early on, I think if I wrote it down right, was around how can we safely implement services if we haven't got staff. It's just to reassure you, we wouldn't start any service in a different way if we didn't have staff. So that nothing will start unless we've got the people with the right skills in the right place. So it was just to reiterate that.
Thank you.
Okay, hope you're reassured by that. So can we hear now from Mary Venturini, who is another person in the audience? I hope I pronounced your name correctly.
Yes.
Good.
I would like to ask about organisation. You're putting a huge organisation on organisations. We've had literature at home. I've been to 3 meetings. We've got all sorts of presentations here this evening. I still don't understand a thing of what's going on. And I don't know how you're going to organise all these different layers. And I feel like the questioner here, that we, at the end of the line, are completely forgotten. We have not been allowed to ask open questions in 3 meetings. And this is the first time that we're allowed to ask questions. And I find that very upsetting. You should be listening to us, not us to you. But could you please tell us how you're going to organise this massive new structure?
The new structure of the way health and social care is going to be delivered.
Well, this Jersey Care model.
Okay.
I mean, it's another organisation on top of other organisations.
Well, I don't think it is. I think it's just a different way of doing what we're already doing. Is that not the case, Anushka?
Yes, so it's not another organisation. So if that has come across that way, then apologies for that. It's a different way of doing things. So the aim is of making the most of the resources that are already here and identifying where we may need to do things differently. In order to achieve that is working with those professionals who are already in the system and with working with users who are going through services. So what works well, what doesn't work, where are silo approaches at the moment which we want to tackle, what needs to be done differently from a clinical professional perspective. All of these things feeding into how can we make things better for islanders. So it's not for the system or for the organisation, it's for islanders. So they basically live longer, independently and more healthy for longer in the place they want.
Mary Benturine, would you like to know how you can give your views?
Well, would it be possible for you then to ask us a little bit more? Because we're the end product, but we've got no feedback. You're not asking us for feedback. We've been told in 3 meetings that we weren't allowed to ask questions. But it's incredibly important for you to ask us what we want, as we've seen here.
So what other questions do you have tonight?
Well, could we have more feedback? Is that could you ask us a little bit more? Could you involve us a little bit more?
Is that possible?
Absolutely, and I think the roadshows were in a way to enable a number of people to ask a lot of questions. We had very good feedback from the individual conversation with a number of providers to have that in-depth conversation. There's always a balance of having an open Q&A, enabling people to speak on their personal matters, and of course not everyone feels comfortable speaking up in a public arena. So we're trialling out different ways of gathering feedback. This today is another way of doing it, but we definitely want to hear more and involve users very specifically in service development. So if you are keen to be involved, more than happy to link in directly with you.
So why don't you have a chat afterwards so that you can get involved with the kind of patient thing?
A lot of people who are very able to speak publicly and want to, and they're not being given the opportunity to, because it's not being taken out to the public.
Well, I think, and I think we are going to be holding more of those kind of things. And we'll be coming to your question shortly, okay? Just going to have a little bit of Slido and then we'll come back to you. So, somebody has sent in a query, why is Jersey adopting commissioning when the NHS, having tried it, is moving away from it? Who knows about commissioning?
Do you want me to take it? Yes. So commissioning is it's a process. So it's not something that the NHS have developed. It's a process. So basically, it's about.
Well, it's about buying stuff, isn't it?
It's not. So
No,
commissioning,
that's what I thought
it's not
commissioning
procurement. Yes, exactly. So there's always that misunderstanding. Commissioning is you have a contract and you buy something. It's not. It's about analysing. It starts with understanding the needs, what is needed by the population. So it usually starts with a public health approach, which was we didn't have that strong public health approach in the past. So the Jersey Care model is developing more public health to help inform us on the needs of the Islanders. Then it's about working together with partners, with organisations across the island. What can be provided in order to meet these needs, and how do we do this best?
So, but why has the NHS not done it very well then, and how will we do it better?
So the NHS have established basically within the system a commissioning group which was commissioning other parts of the NHS. So you had the CCGs which were then commissioning individual trusts. We don't have this arrangement here, and we will not have this arrangement here. Here it's about a working together approach to enable us to define what needs to be put in place. Yes, at the end there might be a procurement process and a contract, but it's the development approach to it which is called commissioning.
So the kind of working together with the charities is what you're saying is the different approach, is it?
Oh, not just charities. It's, with
other
primary, even also within secondary care, what can be provided to meet the needs of islanders for a specific condition or for a specific pathway.
Okay. Where do GPs sit in this new model? All these people who are sending in questions are anonymous. Put your names up, come on. So, Patrick.
Well, as I said earlier, that they're fundamental to delivering healthcare. I think there's two strands to it. There's sort of what is their involvement in the process so far, and the GP colleagues have been involved in a number of areas. The group I'm chairing, we have a GP representative. They're coming to the partnership board. They're sitting in a number of different areas, so they have input into it, absolutely rightly. I think in terms of their delivering care, I mean, we're hearing from our GP colleagues that they're under pressure. They are having issues recruiting, and healthcare becomes more complex over time. So there are more things that can be done in GP practices, but we can't expect GPs to deliver all that care. They need to be, as I said earlier, the gatekeeper and really directing people into the right area where they need that additional help. So I think it's about helping our general practitioner colleagues provide more services within their surgeries, and that's likely to involve them having other healthcare professionals providing some of that care within that, and that starts to get into the discussions about funding. But they're the discussions that we need to have, because if you go into general practice in Jersey, it can be quite different to the UK. The waiting time is a lot less, which is a good thing, but there are other professionals who may be able to provide aspects of people's care more appropriately, and that takes the burden off GPs as well. But we have to work all that through with them and see what that looks like.
To be worked through when the next government is in place and they kind of decide try and figure out how to fund it and how to work together. So it's like there's another 4.5 years to go setting it up, isn't there? Okay, we'll have one more question, then we're going to go to Jean Lelliot in the audience. What criteria is being used to appoint people onto the Clinical and Professional Advisory Forum? And who has been excluded and why? Well, first of all, maybe somebody could say what the Clinical and Professional Advisory Forum is, because lots of people might not know that.
So, as I mentioned earlier, something that I'm chairing, it's a multi-professional group whose main purpose is to start developing care pathways across the whole system of health and care within Jersey. It's really to give that clinical oversight, so any pathways we deliver are clinically driven and are not in the first instance looking around, making sure we're using what is best practice, aware of what the most recent developments within a particular disease process may be. Just going to the who has it been excluded, nobody's been excluded from it. It includes doctors from primary and secondary care, nurses from primary and secondary care, it includes allied health professionals. We've been very careful to try and get a balance between physical and mental health. We have people from neurodevelopmental background, we've got people from research backgrounds, educational backgrounds, and we've tried to make it as diverse a professional group as we possibly can. In terms of how it's come about, well, it's part of the structure, and the recruitment to it, we advertise widely for expressions of interest from all professional groups to get into it. Myself, Rose, and colleagues in public health interviewed for it, so it was by expression of interview, and the selection process was used around that. Again, like other parts of the Jersey Care model, it's not set in stone. People coming into it are there for 2 years, so it can change. There's an expectation about how much they will attend, but it's not an approach that we've taken before. And the other thing which was really interesting is that there were more applicants for it than we had positions for, but absolutely everybody who came for interview, we asked them, because inevitably when we get into more specific pathways, there'll be subgroups that need to be developed and people with specialist knowledge will need to sit in those subgroups. We asked everybody, would you be prepared to be, contribute to those subgroups in the future? And to a man and woman, they said yes, they would. So nobody's been excluded. It's been an open application and an interview process in terms of people getting appointed to it.
Okay. Well, I think we were thinking that we might finish at 8, but I think we've got lots more to talk about. We've got more questions to come from the audience. So if you're happy to stay a bit longer, is that all right? Okay. So if you're watching, hopefully you can stay with us for a bit longer. So now over to another audience question. Jean Lelliot, what would you like to ask?
Thank you. I'll try not to be as angry for hopefully. My question really is about communication. At a PAC meeting, Caroline Landon promised that she would take this back to the parishes. And to quote her, she said she would go to all 12 parishes during the summer. This was June of last year, which she never did. But so that everybody could ask questions about how things would affect them personally. And I've got it all here if anybody wants to see. I've got the extract from the Hansard. She hasn't done that, so my question is, we need better communication, including how these services will be staffed, at what cost and who pays, and when will she take this back to every parish as she promised that she would?
Okay, well, I think probably last summer might have been a difficult time to do in-person meetings, but I'm sure we have talked about doing some more
It was
roadshows.
her that actually said it at a POC meeting that she would start it the following month. So I'm only quoting what she said herself.
Okay.
Okay.
Maybe COVID intervened. So we've already talked about maybe doing another set of 12 roadshows. Hopefully you'll all come along, because sometimes we do parish meetings and 3 people come, which is a bit depressing. But you do think there'll be enough people who would be interested? Well, not about this particular issue, but generally. I've been to many a public meeting in a parish hall, and there have been 3 or 4 people, and there have been more staff than there have been people coming along. But hopefully with this kind of issue, there'll be enough people who are interested, so it would be worth coming. So there's that. And what else? It was the staffing and the funding. That was the question.
In terms of questions, really good. We were a bit limited in terms of times at the moment with the PARA period starting, so couldn't do all of the parishes, but we're definitely working on providing more information and different...
We don't want like this we've had this week. We don't want to listen to the charities. We want a question and answer with the medical people.
And that's actually in development. Feedback we received was a lot of feedback which worked, people wanted to have more of what we've done. We've heard it from you today. So we need to work out so that we have different ways of communicating. So we're definitely working on that. So thank you for that feedback. In terms of what you said, in terms of staffing costs for the new services, we will take that on and we'll provide that as well to give a bit overview, because I think there's specific questions around new services, what they look like, how they're staffed, what clinical professions are in there. So it might be useful to include that in forthcoming communications.
I quote Ms. Landon here from the PAC meeting: "What you get free now, you will get free in the future." That's not actually strictly true, is it? So that's one of the things that needs to be addressed at these meetings. That's definitely not strictly true. And also picking up a little bit on what Rose said before about nothing would be put in place without something, nothing would change without something else being put in place. Well, the closure of Samurai Ward, I'm sorry, but Plymouth was not a good replacement for Samurai Ward, and it was an inferior service. And that should never, it's a bit like selling your car before you have a bus service. That should never have happened. Everything should have been in place before that ward was closed.
I think probably Patrick might want to answer questions about Samurai and Plymouth, because he's been more involved in that than the others.
I think we've acknowledged that there were significant issues with that move, which we're now addressing. I think I'll just make the point it's got nothing to do with the Jersey care model, which is, I think, is why we're here tonight. But no, we acknowledge that the services, when they moved, were not up to the standard that we wanted. We're working on it, we're addressing it. I think there are quite a few things happening at the time. We are still in a pandemic in health. We're still dealing with it, and some moves had to take place in order to move our staff around and change our services during that period. But
also, just to stress, my answer in relation to nothing being started to have got staff in place was a specific response to a Jersey care model question about services.
Okay,
So just to clarify that for the benefit of the audience. Thank you.
Martin.
Yes,
Martin's question was, why are you starting to make these changes when you haven't got all of the answers in place? Should you not actually spend a bit of time getting all of the answers in place before you make the changes? And what you've just said, Patrick, is you've made some changes. I don't know quite what the changes are, but you've made some changes, and now, having reflected upon the changes you've made, you've got issues that you need to deal with in respect to the changes you did make. So that suggests...
Aren't you talking about the Plymouth stroke?
Yes.
Overtaking? Well, this is about the Jersey care model, and the Jersey care model, he hasn't said that about the Jersey care model, has he?
I did.
So we're it's a kind of, it's a 5-year process, so you do have to kind of...
Well, no, I actually think I'm agreeing with you, because what I've said is that when we develop pathways, we will look and we will develop that pathways with input from service users and carers, and before we implement any changes, those conversations will have taken place. So absolutely, we won't introduce changes till we've had those conversations and we understand it.
Care users, sorry to interrupt you, Patrick. Speaking of care users, can we have a body of patients that can have these quarterly meetings that you guys have? Who could give you this feedback?
Isn't there a patient group?
There will be a user group set up
Right.
as part of the Jersey Care model that absolutely works alongside the pathway work. So we have voices of people who've used services, voices of people who've used services involved in that. But I think your frustration is your particular condition doesn't necessarily fit into one of the pathways. So yeah. So let me take that feedback that you've given us tonight, and we'll talk about how we can capture that information.
Speaking on behalf of the patients who have contacted
Yes,
myself that
of
have
course.
nothing to do with mesh,
Yeah.
and they are complaining that they would like to have a voice also.
Yeah.
There is going to be a panel for people to give
So
their
this is
voice,
why I'm
so that's a
asking,
positive thing. I
because
mean,
it would
obviously
be
we
great
can't have
because-
everybody in the island on it, so there will
No,
have to be some kind of process to set
It
that
creates
up.
a working tandem that will, if you listen to me for a second, it would actually give benefit to everyone involved, because it gives our voice acknowledgement, but also gives you what we need.
Yes, it's useful to know that. I think that's what Rose is saying.
It's a huge
And
thing. It's
I think-
massive.
I think in what you've done in terms of bringing the charity sector into the establishment, what you're saying is the charity sector is now part of the Jersey Care model. You've now put, I think, and maybe you could give us your thoughts on this, I think from hearing this evening, the charity sector now almost got a conflict of interest because you're part of the establishment, whereas in the past, and I've been on committees, MS committees, for many years. The charities used to be, if you like, a body that could scrutinise the health care sector. But now you're on the inside. So who is the voice on the outside? It used to be the charity, but now you're on the inside.
So, James, are you part of the establishment now with your charities?
Well, I mean, I don't represent any particular charity. My task is broader than that.
How do you feel the charities think about that?
Well, they can come to the party should they choose to, and as many would be interested in becoming involved, they're most welcome. As I said earlier, I went round and I interviewed 80 people. Now, I fully understand that they're not entirely representative, but to a man and woman, they said that the services as currently operated were unsustainable and things had to change. Now, I don't think the case for change has been made strongly enough, to be frank, but the charities are much closer to the ground because they have people that they're in contact with all the time. They do not represent everybody. Not every condition has a charity in Jersey. But those that are there and are active, they are fully independent. They have their own boards, their own trustees. They're regulated by the Charity Commission, and they absolutely speak very frankly in meetings that I have been to because they have really strong opinions about what should happen. The priorities will vary and we can't do everything at once, and I think that's something else Jersey has to understand, is we can't have absolutely everything that people think we should have, and we also have to really step change in how people approach their own health and how they look after themselves better and take more responsibility. And that's not to blame individuals, but it's simply to say there is such work to do on the preventative agenda, supporting young people particularly, but supporting many islanders to be more careful in how they conduct their lives in terms of the lifestyle that they adopt and how they interact and the risks that they are prepared to take. And it's a balance between the state being very paternalistic and telling people what to do, rather encouraging, supporting change. And the change needs to be really quite rapid around how we consume things, about how much exercise we take, about the sorts of diets that we consume, and there's some really important basic work that we need to get onto. That isn't high tech, it isn't that complex, but it's really difficult because people don't like being told, advised what to do. One of the things I take from COVID is people did understand that they could be more responsible and that they could conduct some of the self-care themselves. And I was impressed generally with how the public just got on with it. And I think we need to capitalise on that and use that sort of philosophy and that approach as we deal with the service. We have an ageing population. We have more people who are going to experience dementia. If we don't sort this out, it will just get worse and worse. So I'm very passionate. That's why I've become involved again after a number of years, because I think we can get it right, and I think we've got to really take some brave steps and just get on with it. To go back and deliberate again and go around the houses again, I don't think that's an option. I think we've just got to get the model. It will be refined as we go along. It will be improvements. There will be step backs, and there will be areas where we haven't got it right. But I think we want a culture where people are open.
You don't think we should go around the houses again? What are you saying? You don't think
We can go back to another. We can go spend another 3 years going around public meetings and parish hall meetings asking.
That's not your decision.
No,
That's up to the
but
politicians.
I'm suggesting to you the case for change is so overwhelming. We've just got to get on with it. I think a lot of people in Jersey are fed up. I think a lot of people in Jersey are fed up about how long it takes things to happen, and people just want action and they want things to move on. That's.
Well, I think public meetings will be easy to sort out whenever, regardless of how quickly things move on. They're always important to see how things are changing, to ask questions, to inform people, even if the care model it's been agreed, it's happening, but still people need to find out more about it, don't they? Just so that you know.
It is a model. It isn't this is set in stone.
Well, nothing's ever set in stone, is it? Things always change.
A model, a principle has been agreed, and that's it.
Okay. I'm going to go back to Slido because there's lots of questions there, and then I'm going to come back to the audience again because I think there's still at least one or two people who haven't asked their questions yet. So, another anonymous person. How will long-term care run alongside the Jersey care model? Is that one for you, Anushka?
Yeah, so maybe just a quick answer. It will run along with the Jersey care model. So the Jersey care model is not there to change long-term care, the long-term care funds. So people will access the long-term care fund as they do at the moment. Jersey care model is there to help people living independent for longer. The long-term care, as it is established at the moment, is really to support people if they're needed.
Regardless of whether it's a new care model or the last one. Or the previous one, that's you'll just carry on.
So it's kind of independent from each other. Yes.
Right. Okay. Somebody's put their name, but I can't read it. Roger de Cabino. Are we looking at privatisation by stealth with this care model?
Yeah. Yes. That's what the website tells.
Anybody like to answer that? Are we looking at privatisation by stealth?
It's quite a political question, I suggest.
Yeah.
So definitely, as a principle, no.
I mean, it's not what was discussed or decided. I don't know how it would happen.
No. Privatisation would mean we would have to, basically shift all services which are public at the moment into in the private space, which is definitely not planned. So I think we have at the moment, we have a very mixed model already in Jersey. We have private businesses, we have private
GPs.
Private GPs. Charities are independent, you could call them private. They're definitely not public as such in a public finance perspective. So we're working together to make the most of it. But the Jersey care model is not a privatisation by stealth.
Okay. Will members of the Jersey public pay for services that were free 5 years ago? And well done, Graham, for putting your name up. Are we going to pay for things that we don't pay for at the moment?
What I can say is there might be a specific question around what were these services which I referred to 5 years ago. We have established new services. We mentioned overnight community nursing care, which is free of charge, so people don't have to pay for that. A number of other services that are being developed, they're free of charge. If there are user pays in the future, if there should be any, it's a political decision. What we're doing at the moment is establishing services within what is free at the moment stays free.
So I guess it'll depend on the budget at the time that the services are introduced and what else is going on and all that kind of thing, and then the States Assembly will decide. I came to the roadshow and thought it was very informative indeed. Have you gathered much feedback from them? And how will you use it from the people at the roadshow, I guess?
So, again, at the roadshows, I accept what people in the audience have said this evening. However, we did have a really good opportunity to have conversations with people. Some people did say to partners that they spoke to around the room, myself included, that they didn't want things attributed to them, and they were quite glad of an opportunity to talk directly to people about their specific experience and their examples. What we have been doing is gathering the information from all of the partners that attended the roadshows, and we had a mix of different partners. They weren't all the same people at the same roadshows.
When you say partners, do you mean charities?
So some of these are charitable organisations that we work with that have been involved in the Jersey care model to date. So we've gathered all that information and we're using that to inform the work going forward. So we're just in the gathering process at the moment.
Okay. Right, I think it's time to go back to the audience. Andrew Bennett, what would you like to ask? Oh, I've heard from you quite a bit already.
Oh, sorry about that. I have a question about when things don't go according to plan.
Which is life.
But before I go into that, I've got a supplemental question about care pathways, because I think we've heard a lot about that this evening, and I think in many ways what we're doing here in this good old Jersey way is it sounds like we're reinventing the wheel. Now, to me, care pathways, and last summer I had to investigate care pathways, and actually I did it very easily. I went to Google and I went to NICE, the UK National Institute of Clinical Excellence, and I could find all the pathways. They're all there, and they're reviewed and they're updated constantly. So actually, I'm not quite sure what Jersey feels it needs to do to develop pathways, because they're there sitting, waiting to be used.
So do you want that question answered, or is that just a comment?
No, I would like that answered, but I'll finish my main question. So my main question is, when those care pathways aren't followed and something goes wrong, what is the mechanism, and how are we going to make sure in this Jersey care model that the failures are actually fully and independently reviewed? And we've done a great piece of work on the island to create something called the Jersey Care Commission. But it seems that actually this Jersey Care Commission, that is staffed with some very clever and experienced medical professionals, many of which are actually based in the UK because they're bringing the help that they could give the island. They're not actually allowed to do their job at the moment because, well, they're just not. So so my question is, maybe you could talk about what you mean by developing care pathways, and what are we going to do in order to make sure that when there are failures, that they're fully and independently reviewed, and how are you going to use the Care Commission? That might be a bit greedy, that's three things, but they're all interlinked.
So, starting with the pathway question, you're absolutely right. We're not going to start inventing new pathways. You're right, NICE is a very good resource, but there's lots of other resources in the UK, but also there's lots of other pathways from similar jurisdictions and bigger jurisdictions. So it's about understanding what world-class looks like, and then understanding how much of that we can implement in Jersey, because if you just take how care is delivered in the UK, for example, it doesn't always work here. We hear that a lot. Don't turn us into the NHS. We shouldn't turn into the NHS, and we shouldn't deliver care in the way it's delivered in the NHS in Jersey in all instances. So we're not going to start making these things up ourselves. We will look and see what's already there, and see how we can bring the best parts of it and contextualise it to Jersey. So that's really what we will be doing. But as we don't always follow NICE guidance on this island, we don't always get things right. And part of this is making sure that we do get it right as often as we can. Healthcare is messy. We will make mistakes, but we want to make absolutely sure that we reduce those as much as you can. It's difficult and it's complex, and things can go wrong, but we have to learn from it. But as we've said earlier on, at the moment, care is delivered in different places by different groups who don't always communicate in the way that they need to. And we don't always understand who provides what type of care, and we duplicate. We need to stop that. That's inefficient. Getting on to the regulation, regulating healthcare. We're a very small island. We've got a small population. We're the size of a small town in the UK, but we provide services that very large jurisdictions provide. It's quite difficult and quite complex. And it's almost the economy of scale in reverse. We're very broad, but then trying to oversee all those services and making sure that it's performing at a high standard requires a very robust governance system behind it. And you're quite right, we need to have external eyes on what we do. The Jersey Care Commission, I think, to be fair to them, are developing. It has been brought forward, so for our services within the hospital will be inspected now in 2024. There's a huge amount of work to do in order for them to come and inspect us. The data information that we will need to provide them we can't at the moment because there hasn't necessarily been investment in IT and data collection and informatics. So there's a whole lot of work that needs to go in to prepare us for that. But absolutely, we need that oversight.
I guess
So that, I don't know if you've got any more questions, but we do need to move on, and we're running over, and other people haven't had a chance to ask a question yet. You just want to kind of say a very brief final what you think.
Yeah, I mean, I guess the challenge is there's people walking into A&E tonight and they may or may not receive the care that they need. And so saying that the Jersey Care Commission will do some work in 2024 just doesn't seem right. That the system is avoiding the external scrutiny that actually ought to be
Patrick,
there.
answer.
So, sorry if I've misled you. Absolutely, every day within the hospital, we look at what we're doing, but we need to do more of it. The Comptroller Auditor General highlighted in 2018 that we need to improve our governance structures, and that takes time, and we have, and there's an awful lot more information now than there has been. So absolutely, all the time, we as executives seek assurance from within our organisation for that. And I've forgotten the next thing.
So I guess what he's asking is what happens. Is there a process for when something doesn't go well? When something goes wrong, what kind of external look is there at that?
Oh, sorry, yes, and that was the other thing I was going to say. We have commissioned ourselves, external reviews. There's mental health, for example, into our maternity services, and very often, when things go wrong, we will commission external reports and investigators from outside of Jersey because we need to.
Okay. And could I just add, just by clarifying, so the Jersey Care Commission currently does inspect and regulate services, out with obviously what Patrick said about the hospital time frame, but we've got across health and community services 17 services that are regulated, that have been inspected, and those reports are in the public domain. So there is already regulation inspection work going on across health and community services. The hospital obviously is the next big part of their programme of work.
Okay, time is pressing on, and we are going to go to our last question now. Last but not least, John Baker, what's your question?
Thank you. Good evening, ladies and gentlemen. A very straightforward question for you. And I'm from the Jersey Action Group, by the way. The new hospital budget is £804 million. There will be 311 beds. That makes the cost of the hospital well over £2.5 million per bed. If the Jersey Care model is supposed to save us money by putting costs to patients over to charities and the patients themselves, then why are we building possibly the most expensive hospital in the world? It seems we will be paying more and receiving less. A straightforward answer would be appreciated.
So we haven't got any kind of, I don't know if any of you have been involved in developing the hospital. I guess Patrick and Rose, you will have been involved in some of the kind of early discussions and ongoing.
Yes, I have to say we all have, and John was at the public planning inquiry for the whole week where we discussed lots of issues. There were lots of opportunities for people to talk about the proposals, and obviously that's in the process at the moment in terms of its planning process.
Yeah, we haven't heard back from the inquiry yet, have we?
So I just think, just in terms of the hospital, without getting into too much detail, because obviously that's already in the public, lots of information in the public domain. But I just want to stress that that whilst Mr Baker refers to the beds, there's a lot more that happens in a hospital than overnight beds. So I appreciate that's quite a crude calculation there, but lots of services happen within a hospital, and it's also a building that will bring together other aspects of our services which are currently very disparate across the island. So that's just a first bit of a comment. I think the next bit of the question's probably more for Anushka and James, if I remember the question right.
Yes, I think it's just to clarify, the Jersey Care model is not there to transfer costs to patients or charities. That's definitely not the aim. The model is to establish more services in the community and to move some of the services which are currently sitting within the hospital environment, which shouldn't be provided in a hospital environment because that can be provided in the community. there's no intention to directly transfer costs from a secondary care hospital to patients or charities, just to clarify that.
Yeah, I think my point is rather the fact that we are building one of the most expensive hospitals in the world if you calculate by beds. At the same time, where this model is expecting the charities and to some extent the patients to pick up extra costs. So my children and my grandchildren will be paying the huge cost for this I think extravagant hospital, but we will also be having to give more money to charities and paying more money for ourselves. And incidentally, this new hospital will be producing for us less services than the current hospital. And you've already had an email, which I'm waiting for a reply to, about the lack of services.
I'm not sure that anybody here is kind of an expert in what's in the hospital and what isn't. Are you, Patrick? I mean, it's not something that Anushka's been involved with.
I'm not aware that we're cutting services out of the hospital, and as Rose has alluded to, there's an awful lot more goes on.
Rose has seen my emails.
And I would just add the educational element again, because it's something we're passionate about. Proper education centres so that we can train staff, keep them up to date on the island. Bringing together physical and mental health services is an absolute must. I mean, in the 21st century, to have those separated is, that's not providing care. And I don't see lots of things in the hospital, new hospital design that we don't need. They're all things that we need, and it's built for the next 40 years. So that there is some resilience, and as I said earlier, one thing I'll guarantee you is that healthcare will change over the next 40 years. It does on a weekly, monthly, annual basis. And we need to have a facility. The facility we work in is dire.
And I think the questions about costs were probably best answered by ministers, because they're the ones who have put all that that system together and have agreed it and have come up with the systems for paying for it, rather than any of the staff. I mean, they would have taken advice from Treasury about how to get loans, but I don't think medics and people have been involved in that aspect of things. So maybe the next Ask the Ministers, with the new set of ministers, is where you need to direct your attention. I'm sure you will, yes. So I think that's it for tonight. I hope you've learnt a bit more about the Jersey Care model and you've had a chance to ask some of your questions here, and I'm sure there'll be opportunities in kind of roadshows around the island as well, because I know it sounds like those are needed in some other parishes. Thanks very much to the panel for giving their time tonight. Thank you to you for coming tonight. It's made it very lively, having a live audience, so thanks for that. And thanks very much to Stage 2 and 3CI, who've been doing all the tech stuff behind the scenes, and to my colleagues who've helped make it happen. Thanks very much to you for watching as well. Good night.